dear committee, dear audience, it's a pleasure to present the progress of my PhD studies, the title of which is Investigating the Efficiency of Arterial and Venous Endovascular Procedures. My name is Dávid Laczkó. I'm a medical doctor and a PhD student at the Department of Interventional Radiology at Semmelweis University. My vision is to eliminate the consequences of peripheral artery diseases by making endovascular procedures more available and widespread. My mission is to provide clinicians with up-to-date knowledge to help them choose the most suitable procedures. In order to achieve this, we have two ongoing projects at the moment. The title of the first project is Investigating the Effectiveness and Safety of Embolic Agents in Bronchial Artery Embolization. It is known that severe and recurrent hemoptysis is a life-threatening emergency with a mortality rate of around 70 to 80%. Now, 90% of these cases are caused by the dysfunction of the bronchial circulation due to inflammation of the lung or lung cancer. There are three possible treatment options. First, conservative therapy, which has been proven to be ineffective in the long run. Another possibility is the surgical removal of a lung lobe, which has a high perioperative mortality. And finally, endovascular procedure, which is the gold standard nowadays. There are three main types of embolic agents that can be used, namely particle agents, PVA, and microsphere, liquid agent, also known as N-butyl cyanoacrylate, and coils can be also used in addition to the previous two agents to reduce the risk of non-target embolization. Our clinical question is, are different embolic agents effective and safe in bronchial artery embolization for hemoptysis? We've investigated patients with hemoptysis either treated with particle agents or liquid agents. Our primary outcome is 1-year hemoptysis-free survival. Secondary outcomes include technical and clinical success, perioperative and 1-year mortality, and complication rate. Our hypothesis is that liquid and particle agents are both effective and safe in the treatment of hemoptysis. In order to answer our clinical question, we've conducted a systematic search in these 5 databases with the following search key. We've found more than 5,500 articles, and in the end, we managed to extract data from 66 articles. We have finished the analysis of the 1-month recurrence, the mortality rates, and the technical and clinical success. And from these, I will like to present the technical success and the 1-month hemoptysis recurrence. On this first plot, you can see the technical success in the liquid group. Now, what is technical success? We can talk about technical success if all of our targeted vessels have been completely embolized. If not, then the procedure is a technical failure. It is a very important parameter because without technical success, there can be no clinical success. The numbers here are proportions ranging from 0 to 1. 0 meaning that during the study, none of the procedures were a technical success, and 1 meaning that all of the procedures were successful. Here you can see that we have 8 studies included. All of them were retrospective observational studies. Although the heterogeneity, it seems to be low risk, we found that the statistics didn't have enough power to give us the true heterogeneity between the groups. The pooled effect size was 0.98, meaning that out of 100 procedures, 98 procedures were a technical success, which is a clinically very excellent result. On this slide, you can see the same technical success and outcome in the particle group. 30+ retrospective observational studies were included. Again, the same can be said about the heterogeneity. The pooled effect size was also 0.98, meaning that out of 100 procedures, 98 procedures were a technical success. And we found that there was no statistically significant difference between the groups. Here you can see the forest plot for the 1-month hemoptysis recurrence in the liquid group. 1-month hemoptysis recurrence is also a very important parameter because this is what shows the true effectiveness of the embolizing agent. Again, the results are in proportions, ranging from 0 to 1. 0 meaning that none of the patients experienced hemoptysis in the first month, and 1 meaning that all of the patients experienced hemoptysis in the first month. In the liquid group, 5 retrospective observational studies were included, and as a result, the heterogeneity couldn't be assessed because the low number of the studies included. The pooled effect size was 0.07, meaning that out of 100 patients, 7 patients experienced hemoptysis recurrence in the first month. Here you can see the 1-month hemoptysis recurrence in the particle group. And again, 30+ retrospective observational studies were included. And here you can see that the heterogeneity is moderate, with 79%. And I highlighted 3 articles that are outliers. The result for these articles being outliers is that these authors investigated patients with lung cancer, and it is known that lung cancer patients have worse outcomes. Again, the pooled effect size is 0.09, meaning that out of 100 patients, 9 patients experienced hemoptysis in the first month, and no statistically significant difference was found between the 2 subgroups. Our strengths are that a large number of studies with a large number of patients were included, and we have a definitive answer to our clinical question. Limitations are that only retrospective observational studies could be found in the literature, and the populations were quite heterogeneous. In conclusion, we can say that particle and liquid embolizing agents are both effective and safe in bronchial artery embolization. What this implies for practice is that there seems to be no risk associated with using either of the agents, meaning that clinicians can decide which agent to use. The implication for research is that investigators should be free to use this data to start randomized controlled trials with different agents. You can see the progress of our first project. We are starting the risk of bias assessment soon. The title of my second project is Comparing the Effectiveness and Safety of Surgical and Endovascular Treatment of the Symptomatic Carotid Stenosis. Stroke is the second most common cardiovascular disease, annually causing more than 1 million deaths in Europe alone. 20% of the strokes are caused by the stenosis of the internal carotid artery. Possible treatments include base medical therapy, either combined with the surgical removal of the atherosclerotic plaque or the endovascular procedure, which means that the insertion of a catheter with the stent is done, and it is dilated. Right now, there's a big controversy surrounding the use of embolic devices. Embolic devices can be used during the endovascular procedures to prevent the further embolization of the brain, thus preventing further strokes. But guidelines don't give an exact recommendation whether to use these embolic filters or not. So our clinical question is carotid stenting with an embolic filter as effective and safe as carotid endarterectomy in the treatment of symptomatic carotid stenosis? We would like to compare patients with symptomatic carotid stenosis undergoing either carotid stenting with the embolic filter or carotid endarterectomy. Our primary outcome is perioperative and 30-day stroke rates. Secondary outcomes include perioperative and 30-day mortality and complication rates. And our hypothesis is that carotid stenting with an embolic filter is as effective and as safe as carotid endarterectomy. Clinical implication is that we could reduce the perioperative stroke rate by choosing the appropriate procedure. So all in all, we have 2 ongoing projects at the moment. The planned submission date of the first article is May, and the second is September. I would like to end my presentation with one of my favorite quotes. If at first you don't succeed, try again. Thank you for your attention.
Regarding your second project, so I don't know exactly, but as far as I know, maybe there is a different clinical indication of surgical intervention and the endovascular procedure. So it means that maybe your study population is quite heterogeneous. So my question is it possible to compare these 2 study groups each other?
I think it is possible.
Okay.
I mean, yes, there are like indications and contraindications for and against both of these procedures, but I think there's a patient population where both of the procedures can be done. And if we include those patients, then they can be compared.
Well, I've been listening to this talk for long weeks, and David, I have a serious concern now, because your pooled result of 98% success with such a very, very tight 95% confidence interval gives me the impression that you are testing the obvious. So it's like, the treatment works. And if I take this thought further, then your research implication that we should feel free to do a randomized trial comparing two agents, it doesn't make sense. Because we have such a tight 95% confidence interval. So what is the difference you are expecting from testing agent A versus agent B? One will be 99%, the other 97% success. And with this, you will need tens of thousands of patients. So do you get my drift? Yes. So what will be I'm playing the devil's advocate now, and the reviewer may ask the same. So what will be your reply to that comment?
Yes, thank you for your question. So what I think that is, it is obvious that both of the agents are effective. What could be randomized, I think, are maybe if we divided the patient populations into lung cancer patients and inflammatory cancer patients, because we can, I didn't show that graph, but there is a significant difference in the recurrence in lung cancer patients and non-malignant etiologies of the hemoptysis. And so the further studies should be focused for these lung cancer patients, and I think there could be a randomization.
Change your research implication.
Yes. Thank you.
Yeah, I have just one recommendation, maybe not comment. So I think I'm also discussing the same thing. So I think you should also make subgroup analysis based on the population, because we clearly can see the last 3 studies were completely outliers with a rate of 40 or 30% recurrence rate. So that's really high rate. So I think if you make a subgroup analysis for lung cancer and have an overall effect for that as well, that's worth analyzing. And what are the other causes for hemoptysis in these studies? So
a lot of inflammatory lung diseases, cystic fibrosis, bronchiectasis, COPD.
So I think if you can subgroup these etiologies, I think it's worth doing in this analysis.
Yeah, thank you.
Just here on the left corner. Okay, so very nice data. Thank you so much. As a respiratory physician and involved in lung cancer treatment, could you maybe comment on the stage of these lung cancers and the histology? So it's very important if it's more like small cell, non-small cell, and divided into different stages, and maybe on the therapy, if they were on medical treatment. Thank you.
Thank you for your question. This is a really good idea. We wanted to do it, but unfortunately, these data were not published in the articles. There were maybe one article that described the stage of the lung cancer, the histology of the lung cancer, and the treatment. But the others only mentioned that patients had lung cancer, unfortunately.